Some people may be in time zones of morning. Good evening if you're in that kind of time zone. Once again, thank you for joining us here today on Own Your Health. And our topic is looking after your feet. Looking after your feet. My name is Flora Coker, and I'm the founder of Encapsulate Healthcare Solutions. Thank you for joining. I'm going to go straight into it because it's already 7 minutes past 4. Today, we have two amazing experts that will be sharing their knowledge with us on this webinar. Our first speaker, co-speaker is Fumi Ogunyoye. She's a podiatrist with over 30 years experience in dealing with foot problems. Our other co-speaker is Dr. Gerald Agbarakwe. He's a lecturer in podiatric medicine in one of the universities here in the UK, and he also works in private practice. As they're presenting, they'll tell you more about their roles and what they do. So straight away, I hand over to both of you, Fumi and Dr. Gerald. The floor is yours.
Thank you.
Thank you very much. Thank you for the intro. Fumi, I'll let you go first.
Thank you so much. Lovely to see everyone here. I hope you can see the screen. Is it clear? The slides? Yeah, wonderful. So myself and Dr. Gerald are going to be co-presenting. I am a podiatrist. I have been doing podiatry for over 30 years this year. What we do basically is we specialize in feet and, foot problems. Some podiatrists go even further and they, do further qualifications and they do much more specialist things, for example, surgery and other things that are, much more, complex. So Dr. Gerald will probably tell you a bit more about that. But what I do is I do general podiatry. I've worked in the hospitals before, done hospital setting, community setting. And so at the moment with the sort of work I do, it's covers general foot care issues, not something that needs sort of acute care, hospital care. If that is needed, then obviously we make referrals on. Okay, so I'm going to start with talking about some amazing, fun foot facts. And as we know, what is keeping us standing? Our feet, these 2 feet, from the day we start walking till the day we leave this planet, we are relying on our feet to get us from A to B. So the feet do a lot for us. And obviously, because this is just an introductory talk, we want to make it as, compact as possible. So generally speaking, the feet have 26 bones, 33 ligaments. So as you can tell, that's 52 bones you're looking at just to keep us standing on our feet. Quite a lot of joints as well. So with all these bones, you're going to have quite a lot of joints in there. And the foot needs to act in a way that propels us forward. So it has to be flexible and it has to be rigid at the same time when it's doing different things, when we walk, when we run, when we're doing activity. And the average person, it is said, takes about 8,000 to 10,000 steps per day, which is quite a bit when you look at it in our lifetime. They say we can walk up to 3 to 4 times around the globe. Right, so we're going to move on to the next slide. Having said that, with the foot being as simple as it is, because we just walk, we don't think about it when we walk generally. There are lots of things that could go wrong. If you imagine, all the joints that are involved, ligaments, all the muscles, the sort of loads that we put on our feet, especially during different parts of our lives, for women, if they're, having children, put on weight, and, lots of other things that can happen. There's some people that are more susceptible to certain foot problems because of maybe general health problems they may have. Some people have rheumatoid, lots of other things. My colleague Gerald is going to talk about, one of the more common ones that we are more concerned about here when it comes to podiatrists and foot and health problems. But the common foot problems we're going to discuss today are bunions, hammer toe, plantar fasciitis, ingrowing toenails, toenail fungus, and an athlete's foot. And also my colleague is going to talk about diabetic foot as well. So we're going to deal with that a bit later on. So I'm going to start with bunions. So when you look at a bunion is where you have this problem around the big toe joint. With some people, they get like an enlargement of the joint, and it can cause other parts of the foot to be affected in many cases. So sometimes people will see this bowing of the joint, and obviously the obvious thing is it makes the foot wider. People get a bit of maybe inflammation around the joint and pain and bony changes that can happen because of all of that. And then the fact that it changes the structure of the foot, in many cases, it can affect the other toes as well. And then people have to consider maybe wearing wider shoes. Some people, the pain might be so acute, maybe if they have a job where they're standing, they might have to put some padding in their shoe to just make them comfortable. Some people, to sort of treat the problem, they might have like special insoles put in their shoes that can maybe help assist the way the foot is walking. And then in some cases, if it's really bad, some people need to have surgery to deal with the problem. And the surgery might be to not just the bunion, it may also be to some of the other toes as well if they've been affected. Okay, so we're going to move on to the next foot problem, which we listed, which is hammer toes. If you look at the bottom slide, the bottom picture in the slide, where it has a picture of the toe that's like it says a corn on the top and plantar callus at the bottom. So when you have this is looking at this toe, it could be the second, third, fourth toe, but generally it's the second toe where the toe bends. So it affects the foot in such that you'll get pressure on the top of the toe. And in many cases, people might get like a corn. And then also because it pushes the joint at the base of the foot, it pushes that down. So it might disperse where the foot padding is that we have generally that keeps us comfortable. Some people will get hard skin there because, it's taking more pressure. And, the problem you have with that is in many cases, this can be associated with bunions as well, but when you have abnormal muscles like pulling in different directions of the toe, it will cause this deformity to happen. And, what can we do about that if we have that problem? Again, we have to look at our footwear. And the best thing to do, obviously, is to look at your shoes, look at your feet. We look at our feet and we think, is this footwear that I'm wearing, does it accommodate my foot adequately? And in many cases, even when I'm dealing with like patients with inappropriate footwear, what I tend to do is a general exercise where I'll put a piece of paper on the floor. I will draw around their foot, tell them to please stand. When they stand, the foot will spread a bit, draw around their foot. Then I'll look at the shoe, we'll draw around the shoe and we say, how can this go into this? So sometimes for some people, that's what it takes. But generally speaking, people know that maybe the footwear they might be wearing might not be appropriate. So the key thing is to look at the shoes, wear something that's wide and deep enough for the foot to accommodate it so that it prevents having any pressure being rubbed on the top of the shoe. And then sometimes at the bottom of the shoe, maybe if you have areas where it's hurting because there's pressure there, some people might want to put some padding. Some people might have special insoles again. And in many cases, if none of those help, there's always that option where some people will have like surgery as well to try and, rectify the problem. Okay, so the next common foot problem we're looking at is plantar fasciitis. So this foot problem, has some nicknames. Some people call it policeman's heels, but generally speaking, it's an inflammation in the band of tissue along the bottom of the foot, around the heels especially. And if you have a look at the picture there, it sort of shows you generally where the pain is. Also, for some people, it might even be a bit further away from that point, but generally speaking, it's around the heels. Most people complain of this. And if you have this problem, which is very common actually, because I've had an episode of this myself, which I then understood what people were talking about. When patients come to you and say, oh, in the morning, they get up, first thing, it's like standing on nails or whatever, and then it goes away. The pain goes away slowly, and then they stop for a while, or maybe they sit down and then they stand again, and then the pain starts. So basically, it's caused by the tissues becoming strained over time. Very, very common, especially for people that walk around, people that stand. And the key thing is, what can I do about it? Because when it comes, it can just come suddenly like that, and then the same way it can also go suddenly. But the key thing with it is it does need to be treated. And there are ways of treating it. If it's very, very acute, some people can put ice on it. One of the general ways that I recommend, which also worked for me as well, was stretching. Doing some calf muscle stretches and some other stretches to help with easing the tension around that area, especially first thing in the morning. So first thing in the morning, instead of just getting out of bed and just carrying on walking, it will mean doing a few stretches, stretching that area to help reduce the inflammation, so that gently, gently the area is dispersed of the inflammation that causes a lot of the pain around there. Then the other thing that needs to be done as well is IWA trainers. And I always recommend this to my clients, if they're able to at their workplace, is to wear something supportive, some trainers that will help take some of the pressure maybe off that heel area or support the heel area, and also give them a bit of cushioning as well. So that's something to, look out for. Trainers, if you can negotiate with your workplace, because some workplaces are very, strict about their, uniforms and what they want people to wear. But if you can maybe explain to them if you're going through an episode of that, and then they might be able to make some adjustments for you. In some cases, though, when people have the plantar fasciitis and the pain is really terrible and debilitating, sometimes people can get like a steroid injection that can ease the pain and, give a lot of relief in a very short period of time. So that usually for me is like a last resort. I'll, refer patients to have that discussion with their doctor. But it's something that can be done, and, doctors know about it. So it's, if it's really, really bad, you always know that there is a solution, that can be, can give you some rapid relief, very likely. And then, of course, in some cases, some people may need to have like surgical treatment, which is not, very often. That's much more rare. But it's something that goes, and it's something, that's very common. Just so if you ever find yourself in this situation, don't think, oh, what is it? The first thing to do, obviously, is to maybe speak with your doctor, speak with the pharmacist as well, because they will probably be aware of this. Some might even have some like gels that you can rub in the area that might actually help with soothing the area and giving you some temporary relief. Okay, so I'm going to move on to the next slide, and which is ingrown toenails. So this is it's quite self-explanatory. It's where the nail, grows and causes a bit of problem in the corners, generally speaking. So, this can be caused by so many different reasons. Some people get it by trauma. Some people, maybe they hit their foot and damage the nail, cause some, distortion in the shape of the nail, and it starts growing down the side. Some people, maybe somebody steps on them. Some people cut their nails in such a way that it can encourage this to happen, if they cut their nails in the wrong way. And with some people, it's genetic. There's some people that just have nails that are, very curved. We have a lot of children, we see with this sort of problem. And the key thing to do with that is, when we treat this here, we tend to, have like either a conservative manner of treating it, or in some cases, some people may need to have some minor surgery to have a section of their nail taken off, or sometimes the whole nail, which can, happen if the nail is really badly ingrown. In some cases, some people might need to get some antibiotics from their GP before then. So if it's something that's pussy and so painful to touch, you may want to see again the pharmacist, because the pharmacist might have something that you can apply, maybe some antibiotic cream or some other sort of intervention before considering having like surgery. But generally speaking, conservative treatment can help. But if it's a problem that's recurring, you may want to see maybe the doctor to see if it's something they could do, like as a minor, minor surgery. Okay, so I think this has sort of covered the topics we've put here as common foot problems. I will say, obviously we just picked these problems to use to illustrate for now. My colleague is going to continue, but if there's maybe any problem that someone is thinking of that we haven't listed here and they want to maybe ask us about, feel free to mention it in the chat to Flora so we can pick this up, when we are doing the questions and answers.
Yeah, actually, yes. Before Dr. Gerald goes on, we can take some questions now.
Okay.
If you have any questions, I haven't seen any in the chat yet, but if you have any questions, you can put your hand up now about what we've just discussed or any other condition that you want to ask about. We can take that quickly before we move on to the next part of the presentation. Okay, Della, go ahead. I've asked you to unmute.
Yeah, hi, good afternoon.
Good afternoon.
Yeah, thank you so much. I just joined.
Yeah.
What I want to ask is, my daughter has her nails, the toenails and the fingers are very dark, and she keeps complaining, "Mommy, you need to take me to the GP." And so I don't know, because the dad's and the siblings' toes are like that. The color is dark as well. So I've told her I don't think there is anything wrong, but she keeps bothering me. So as soon as I saw this right now, I'm like, okay, if there is an opportunity to ask the question, I will ask and see if I need to take care or it's just normal. Thank you.
All right, Gerald or both of you, do you want to take that?
Well, I mean, I can start by suggesting, firstly, if you don't mind me asking, when was it first noticed, this problem? Right. Well, what I wanted to ask was, is it a new problem? Is that how it's always been?
That
Della,
is
go
how
ahead.
it's always been. That is how it's always been.
Okay. And how old is the child, if you don't mind me asking?
She's 13.
13. Okay. So since she was born, basically, you're saying it's been like that?
Yes, because her sibling and the dad, I realized the dad's nails are also like that. So I told her that I think it's normal because your dad doesn't have any health issues. So it's not like it's something to do. But these children are watch so much TikTok and all those things. So she just come up that is something.
You see, it's unfortunately,
that is what I'm thinking.
Because I haven't seen it, right? I haven't seen it, but based on what you're saying, are they straight lines going from the top to the bottom? Is it the whole nail is black?
Yeah, there is a line.
Straight lines, okay.
Yeah.
Okay. I mean, I will let Gerald speak as well, but there's something I think called linea nigra is what is coming to my mind. Because some people may think it's a fungus, but I'm really doubting it if, from what you're saying, is from birth. Is it on all the nails, fingers and toes, or just specific ones?
Yeah, it's all of them. And I think the dad had that, and he is okay. He's never complained that there is nothing wrong with him. It's just this child thinking, "Mommy, you need to take me to GP."
Do you mind if I ask where you are based?
In the UK, please. Yeah.
I mean, my own take on this would be, for the sake of listening to your child and for the child to feel they are being heard, and also to reassure the child, the child is going to be an adult in 5 years. And I think it's good for you to show you're taking an active interest in their health, whether or not there's anything, there. From what you're saying to me, and you see, I really don't want to say there's nothing wrong, because it's not right for me to say that because I haven't seen it and I don't know and I've examined it. But what I would say is, my own opinion is it's good to reassure this child, take them to the GP, because you want this child to care for themselves. Look at the bigger picture of other things that could be going on as when they become an adult. They have a problem, let them go to see the expert. The GP might refer them to a dermatologist, possibly. It could be something that's affecting their self-esteem. You just don't know. There might be other reasons, because for you may think, oh, there's nothing wrong medically, but you don't want it to be, it might be something affect them in other ways, and there may be solutions. So just because maybe the father has put up with it, if there's nothing wrong with it, and it's a genetic thing, there might be other cosmetic ways of, dealing with this and getting the child to know this is how you deal with a problem. If you have a problem, there's a way, there's a process, you know what I mean? And empowering them. So that's just my thinking, but I'll pass it on to Gerald if you don't mind.
Thank you very much for me. Well, I mean, from what you've explained, it sounds like something that is quite common among darker skinned individual. I do have one myself, and at some point I was worried about it. And I went through the whole process of having pathology test, and it came out as nothing. But that being said, just like for me explained, it's important to take her to the doctor so they can review it themselves, put it on the records that she was there and she was seen for that particular issue. If there's need for that, they can take samples like nail samples or nail clippings and send it off for pathology test as well. It's better it comes back negative than just leaving it and there's like an underlying issue that's not been addressed as well. So that would be my take on it. Apart from that, saying that it's common in Black individual or darker skin individual, things like tight footwear as well can contribute to that because of the melanin in our body and on our skin. When you have very tight footwear, it could be something that she's been wearing from birth. It impacts on the cells in the nail, and you can get that dark streak around there as well. So footwear assessment will be very important, just making sure she's wearing the right footwear. If you want, you can also speak to a specialist like a podiatrist to carry out a footwear assessment just to make sure she's wearing the right footwear and she's not getting too much pressure on the toenails. Yeah, that would be my take on that. I hope that helps in answering your question.
Yeah, brilliant. Thank you so much for your help. That really helps. Thanks.
Fabulous. Okay, next question. How often should we have pedicures? Who wants to take that?
Well, I'll let Fumi take this one.
All right. I'll bounce that to you. But you see, it all depends again. Now, a lot of things depend on an individual. Personally, for me, I mean, podiatrists work in different ways. There are some podiatrists that do pedicures, some do medical pedicures, even some will paint nails and do the treatment. But the kind of work I do, and I make it clear to people that come to me for treatment, is I don't do pedicures. I'm not here to make your feet pretty. I always tell this to people so they can go somewhere else. And there's nothing wrong with that because, I know of some podiatrists. I have some colleagues that they have specialist pains, this, that, and the other, and they like that. So if it's from a medical point of view, 3 monthly is sort of a routine thing if you have no problem. So it all depends on each person. I won't say there's a rule. You understand me? Because everybody's nails grow at different rates as well. And everyone has different issues. So if you have the person with corns and hard skin and you're going for treatment for that, maybe 3 to 4 monthly. There's some people I see every 4 weeks because they need to be seen every 4 weeks. So it's really varies is all I'll say. If you don't mind, Gerald, I'll sort of take
that covers it all, to be honest. How often depends on the patient and preference. There are patients that want to be seen weekly. It's just like having a haircut. There are some people that have a haircut probably once a month. Some people do every week, depending on where they want to be. So if it's not for a medical reason, then it's just routine pedicure, then it's up to you as much as you want it. The only advice is something that we're going to talk about down the slides. It's just making sure you're going to the right place and making sure they're using the right equipment as well, because the chances of getting an infection when doing routine pedicures in non-medical places it is quite high, actually.
All right, thank you for that. So next question, and then we'll continue with the presentation. What causes bunions? What are the causes of bunions?
I think I can start on this one. Bunions are, like Fumi explained, you get medial deviation. I actually have a bone model here. So you get medial deviation of this bone and lateral deviation of that one. Okay. And it's just this bony bump puts pressure on that skin, and then you get redness, inflammation, pain. Sometimes the bones or the joints in here will be arthritic as well. So you get arthritis of the bone. So it might be difficult to bend. So you can't even walk properly because your biomechanics will begin to change in that case. Causes can be different things. Number one, it can be genetic. I've seen patients that probably the dad or the mom has bunions, never caused them any problem. It's gone to stage 4 bunion. They're even walking on top of the big toe and they've had no pain. But the patient comes in, patient's about 40 something, and they have a massive bunion that is very, very painful. So genetics will play a role. Apart from genetic, trauma to this area can also contribute to having a bunion, depending on your line of work. Probably someone that drops a brick on that particular area of the foot, you damage the healthy tissue around that joint, and it progressively starts to deteriorate. And before you know it, you have a massive bunion as well. Wearing very tight fitting shoes. I made a video recently about wearing high heels with no offense against those that wear high heels, but high heels are known to have very narrow toe box. So what happens if the toe box is too narrow? It cramps the apex of your toes, and what you get is something like this. If you just started wearing high heels today, if you take the high heels off, it might come back to the same position. But imagine using that for a very long time. The joint will begin to assume that position. The muscles and the tendons will begin to constrict as well. So footwear, genetics, trauma are some of the main causes of bunions.
Right. Okay. So there we go. Let's let's carry on with the presentation, and then we'll take questions after that
Okay.
session. Thank you.
Can everyone see my screen?
Yes.
Good. Give me a second. Right, so I'm going to start with toenail fungus. Now, fungus, they're very common, around us, and there's some living on our body as well, but they don't cause any problem at all. Down the line, when people begin to get, maybe you have a contact with somebody that have had this fungus and your immune system is not strong enough, you begin to see signs, things like this. So discoloration of the toenails, one of the things that you will see. It might begin to itch. You might get this dryness around your feet and skin as well, and the little patches as well. If you check in between the toes, you might see, something called athlete's foot, which is something I'm going to talk about down the slide, but that can come alongside the toenail fungus. Sometimes the toenail fungus could lead to an athlete's foot, or you could get athlete's foot causing the toenail fungus as well. And it can be very itchy and sometimes painful. So taking discoloration of the toenail, and what happens is that they thrive in a very damp environment. So places that are not well aired, say wearing footwear that are very occlusive, not breathable, wearing them for a very long time, wearing socks that are quite wet. It just gives them the room to breathe and proliferate. And with that going on for a very long time, patients will start getting fungal nail. patients with certain medical conditions as well, like diabetes, that could cause reduced immune system. They are also susceptible to having this fungal nail. Now, saying that, I'm just going to go back up. There are some patients that might have nails that look like this, but it's not necessarily a fungal nail. It can be as a result of trauma, playing football and wearing those tight football shoes for a very long time can contribute to traumas to the nail. So what we do is we can take a sample and send it out to confirm if it's actually a fungal nail or not. Ways to prevent it will be to wear shoes that are fit and well with materials that break, and as well as disinfect your shoes and your socks. So if you want to wash your socks, it's important to wash it inside out, wash it with very high temperature, and as well as swap your socks every day. Okay. So if you get people that I've seen a case of a patient that came in to my clinic, and when they take the socks off, it was wet. And when you ask them how long you've been wearing the socks for, and they said they've been wearing the socks for about 4 days. Typically, when you look at a patient's toenails, you just see it was just a clear presentation of toenail fungus. So apart from the patient expectation to get that treated, we had to do some lifestyle modification advice, like, washing your socks properly and wearing the right footwear and changing them every day. In terms of treatment, it's important to take a nail sample or nail clipping and send it off for testing. Sometimes it can come back negative. It can be a false negative or it can be false positive. Essentially, what that means is that it comes back negative, but there's actually a fungal infection there. So we call that a false negative. Or sometimes it can come back positive and you get false positive test depending on how the test was done. Okay. So if the test comes back positive, there are a few things that we can do. There are some antifungal spray that the patients can use twice daily. And when they use that over a period of time, you can see that toenail fungus start to clear off. There's also what we call laser treatment. So laser treatment is more like a modern type of treatment that recently came out. They use that it's like tiny little lights to zap that area with the fungus just to kill them off. Another treatment, I don't usually recommend that, but I do at some point when it becomes really serious, because the issue is that if it goes on for a very long time, you might get that fungal infection being superimposed by bacterial infection. So patients can come in, or they've been coming in with fungal infection for a few months, and before you know it, you start getting pus around the skin or underneath the fungal nail. And essentially, if you test that, you see like a bacteria breeding under the toenail as well. So that's one of the reasons why it's important to get it treated as soon as possible. So the other treatment line, which is a step up for me, what I do is probably refer them to the GP, where they do a blood test to check liver and kidney function, and then prescribe them tablets, like antifungal tablets to take to help clear that fungal nail infection from the fungal infection from the system. This can take a very long time. Patients sometimes come in expecting to get it cured within 2 days or a week. What we tell them is that this can take a long time. Sometimes you might be taking that medication for over 6 months. Sometimes you might be using the spray for more than 2 years as well, because they're quite stubborn and they hardly clear off. So combining that with lifetime modification will really be useful in the treatment process. Outlet foods is another one. So this is quite common in patients with that are immunosuppressed as well. You get this dryness of the skin, whitish areas as well with patch. Sometimes it can be itchy. It's a skin disorder that is caused by fungus and it's thrive in damp areas as well, just like the fungal nail. Symptoms, like I said, will be itching, dryness, scaly skin, and sometimes you get redness. And superimposition with bacterial infection as well. You can get redness around that area of the fungal infection. Treatment will be antifungal cream. Now, importantly, in terms of cream, there are some people that try to use the normal moisturizer It could be Nivea or, other products just to moisturize the feet. If you have a fungal infection or an athlete's foot that is looking like this, it's important not to use your regular daily moisturizer around it, because what you're doing, you are feeding the fungus, and they like that sort of environment, and they will breed, and they will just increase in number. There are special antifungal creams or ointments that can be used when you have a fungal infection to help to kill the fungus themselves, and as well as moisturize the skin. Are there any questions about fungal infection before we move to the next one?
No, yeah, we'll take it when you finish this session.
Okay. The next one will be diabetes, which is a condition that affects different parts of the body, but today we're talking about the feet. So I'm going to focus on the feet. So diabetes is an inability to manufacture or properly use insulin, which is, one of the hormones in the body that helps us to regulate blood sugar. So inability to properly regulate the blood sugar, and if it's constantly high for a very long time, patients can have issues with the eye, maybe sight might be affected. They can have heart problems as well as kidney problems. And when you come down to the feet, the nerve and the nerves and the circulation in the foot can also be affected. Looking at recent study, it says that the prevalence of diabetes in Nigeria is increasing. Hence, the need for us to be more proactive about our health and check the different areas that can affect our foot or our overall body. So we need to check our feet regularly. And if there's any problems on the feet, we need to see qualified healthcare professionals to address it. Now, you may ask that what are the warning signs of diabetes in the foot? Okay, one of them would be change in the color of the skin and temperature changes as well. So because diabetes affects the blood vessels, you might have reduced circulation in your foot. And because of reduced circulation in your foot, you could get that changes in the color of the skin. You might start to, get a skin that is a bit pale looking as well. Sometimes when the nerve is damaged, you don't get that regulation of the blood vessels as well. You might get redness and then it goes pale. So the regulation will not be as it's supposed to be. You might also get temperature changes. Patients might come in, or you might feel when you touch them or touch the foot, it might feel a bit cold or cool to touch. Sometimes it could feel too warm as well. So that regulation will not be there because of the damage of the blood vessel and the nerves as well. Swelling of the foot and ankle can be attributed to so many things. It can be due to medication or kidney problems. But in terms of diabetes, it can be a combination of different things. Okay, so it's one of the things to look out for as well. Numbness of the feet or the toes, this is a very big one when it comes to diabetes, because this is one of the reasons why patients present late into clinic, when they have a foot wound or an ulcer. So when there's damage to the nerves in the foot, the patients will not get that protective sensation. So if they step on something sharp and it cuts their foot, or maybe they have a wound or blister from wearing tight shoes, they don't know because they cannot feel any pain. That protective sensation has been lost. And what happens is that some patients might present when the wound is starting to get infected, and they begin to perceive that odor from the foot, okay, because of that poor sensation. So numbness in the feet and the toes would be one of the things as well. Open sores on the feet that are slow to heal. So if you notice a wound in your foot and it takes forever to heal, then it could be one of the telltale signs of diabetes. And in that case, it's important to go have your blood sugar checked just to make sure that you're not diabetic. Pain or cramping can happen in the foot. It can happen in the calf muscles as well. This can be attributed to circulation problems. So if there is poor circulation in the feet, patients can begin to feel pain. If you do any little activity like walking, you can start getting cramping of the muscles in your calf. because of that poor circulation. You can start getting cramping sometimes in different parts of your foot, as well as pain. So how do we care for our feet, or how do we take care of a diabetic foot? There are different things that we can do, or different things that you can do as a patient as well. Number one will be to inspect your foot daily, especially in between the toes. This is quite complicated, especially if you consider the social factors that might hinder the inspection of foot. Some patients are elderly and they live by themselves. Some of them could have back problems. They cannot bend properly to investigate their foot. Some have visual problems as well, so it might be difficult to see. So if you have elderly members of the family that are diabetic, it's important to also, go have a look, check your foot, check between their toes. Patients that cannot bend, we advise them to put a mirror on the other side and sit with the foot facing the mirror and just have a look just to see if there's any changes, redness or anything, so you can consult the right professional. So daily inspect the foot for blisters, redness or swelling, especially in between the toes and the heels as well. Wash your feet with lukewarm water and mild soap, drying them thoroughly, especially between the toes, because what happens between the toes is when it's not properly dry, it will begin to macerate, it will begin to break down, and then you get this tiny little blisters and cuts in between the toe that can progress really quickly to a massive ulcer in a patient with diabetes. Moisturizing the feet regularly as well is very important, avoiding between the toes. So when you put cream on your foot, apply on your tippy toes, try to avoid between the toes if you can. Okay, the reason why I say that is because with water or cream in there, imagine putting cream between the toes and wearing the tight socks in the hot weather with an occlusive shoe. It will begin to macerate and break down as well, and that can increase the risk of having an ulcer between the toe. Moisturizing is also very important because it leaves your skin soft, nice, and supple. There are special moisturizing cream that you can use to help to reduce that risk of having a dry skin. For a patient with diabetes, if the skin is too dry, it can easily crack or break open. And once it cracks, and you have all those fungus that live on the skin, combined with a reduced immune system, once they make their way through that crack, it will begin to cause a superficial skin infection, okay? An infection or redness around that skin, which can be a massive problem. Sometimes patients might have to go to hospital to have antibiotics go through their vein, to help them clear that infection. The next bit will be to wear well-fitting shoes and avoid walking barefoot. The reason for this would be if the shoes is well-fitting, then the risk of having corns, calluses, which are like very heavy hard skin around the foot that can progress into an ulcer, will be greatly reduced. And if you avoid walking barefoot as well, what will happen is that the risk of stepping on something sharp will be greatly reduced as well. So a patient that has poor sensation wearing footwear indoors and outdoors will be very, very helpful. And saying this in terms of footwear, for those that have kids that have little toys that play with their toys, and sometimes you find your kids' toys in your shoes. I mean, it's possible, and patient says it does happen. So before you put your shoes on, take your shoes and dip it, and sometimes you can run your hand in there and just make sure there's nothing in there before you put your shoes on. Schedule regular foot exams with a healthcare professional. For a patient that has diabetes, those that are low risk, we tend to see them once in a year. Those that are at medium risk, there are different criteria that we use to place this patient on different level. We advise those with medium risk to see the professional every 6 months. A high risk patient will be a patient that has an active wound, or a patient with diabetes that have had a wound in the past. So we encourage them to see the podiatrist at least maybe once a month, as long as there's no active wound. If there's an active wound, then you have to go regularly. It could sometimes be every 2 days or every 3 days until that issue is resolved. Then you can go back to your monthly routine check. Someone asked about having a pedicure. You know, well, I will say that's very good. It's important to also know that we need to avoid hot water. Sometimes when you go to the pedicure places, they have this warm water, they call it, but sometimes it could be hot. But for a diabetic patient, if they don't have any sensation in the food and they put it in that hot water, they cannot tell that it's too hot. And by the time they take that food out, give it just a few hours, it will lead to blisters that can lead to ulcers and ulceration as well. So avoid hot water and heating pads on the feet. If you want to have your shower and you put hot water, you can try and check it with your hands or check it with your elbows as well, because sometimes people can also get neuropathy or loss of sensation in their hands. So you can check it with your hand and you feel like it's normal. Then you put your foot in there and you just get all these blisters coming up. So keep the blood sugar levels under control as well. Engage in regular low impact exercise. Things like walking can do your foot a lot of good. So walking helps to strengthen the foot muscle, also helps with the circulation process. So the blood flow in your foot, the more you walk, the better for you. Okay. So I'm not saying do 10K, 20K walks a day. Just do it to a level that you can tolerate. Smoking is one of the the activities that contributes to poor circulation as well. So for a patient that has diabetes with smoking, it just increases the rate of you having problems with your circulation, especially if your blood sugar is not well controlled. So quitting smoking will be very important. I know it's easier said than done. And if you need help, I believe there might be some smoking cessation centers that can help you, with quitting smoking. So quitting smoking is very important if you want to have if you want to take care of your food for a patient with diabetes. So the next session, I know everyone is wondering, why do we have high heels here? I know there's some men here as well. If you
Gerald,
have...
sorry. Before you go ahead, let's take some questions before you get into these heels.
Oh, great. Wonderful.
There's quite a few questions in the chat. So let's do that. Just stop sharing for me for 1 second.
Okay.
Let's take the first one. Okay, someone's asking, how safe is it to have the toenail removed by surgery due to an underlying infection? Is surgery always the answer?
Thank you very much. Oh, Fumi, do you want to take that or do you want me to take it?
Go ahead. Go ahead.
Okay. Thank you very much. It depends. I mean, it's a straightforward question and it's not so straightforward at the same time, because there's a pre-surgical assessment that we do just to make sure that everything is as we want it to be before we can proceed with the surgery. Toenail surgery or toenail surgical removal of the toenail, it's very common and very straightforward. It can be done within a few seconds. The only complex part about it is getting that anesthetic in to numb the toe. So it's quite a safe procedure to do. Now, the only issue would be if a patient is diabetic, right, and the blood sugar is not well controlled. Okay, that increases the chances of the patient having an infection if we go in there and intentionally cause that surgical wound in that patient. Apart from that, if the patient is taking some medications that like blood thinners, okay, that does not, let's say if the medication is not being checked and it's not properly controlling what it's supposed to control, we might go in, do the surgery, and the patient just, keeps bleeding and the bleeding doesn't stop. So we make sure that the patient's blood sugar is well controlled before the surgery. We make sure that the medication that is meant to regulate or thin the patient's blood is at the right level before we can, agree for that patient to even come in to have that surgery. But if there's an infection that's going on, we can combine that with prescription of antibiotic. Sometimes they might have to have a systemic antibiotic, depending on how serious the infection is, just to make sure we're covering every area. So it's quite safe. We just need to make sure we do the right assessment and choose the patient wisely.
Thanks, Gerald. Fumi, do you want to add anything else?
Well, Gerald has said more or less the key thing. I mean, obviously, when they have their assessment, we have to also check things like if they've had any allergic reactions or all of that to local anesthetic. And then the infection, say you've mentioned here, I'm assuming is a infection caused by ingrown toenail, not fungal infection. But if it were that, I mean, it probably wouldn't make any difference because the response will still be the same as to what, Gerald has said. But I think the key thing is to go and have an assessment done. And like he said, whoever does it, we have certain protocols we have to follow. And, anyone that's going to do something like this will follow the necessary protocols. So it is generally safe if the person is suitable, as already, yeah.
All right.
Just to add to that, when you say infection, if the nail is already in the skin, right? You get patients that have had antibiotics and things like that, and the infection goes and then it comes back because that offending nail is still in the skin. So to properly clear that infection, we might still have to do the surgery to take that offending nail off and prescribe some antibiotics for the patients that will finally clear it off and so it doesn't come back. So it's quite a safe thing to do. We just need to make sure all the assessments and corners are covered.
All right, great. Thanks, both of you. All right, next one. Can bunions be cured or corrected? And what are the chances of having straight toes again?
Bunions, yes, they can be corrected. But when you say corrected, then it has to be surgical. Okay. In terms of management for bunions, we do group it into conservative management, where conservative in the sense that it's non-surgical. So things like wearing wider fitting shoes, spacers, toe spacers to try and put it that way, push it towards the side. I've seen some devices online that claim it can correct the bunion. You just need to attach it and twist it, and then it moves it. The thing is, if there is a change in the structure of the bone, it has to be, to correct that, it needs to be surgery. Okay. With bunion, if it's not painful and it's not causing any problem, you don't have any ankle pain, knee pain, or lower back pain, it's not contributing to anything, my professional advice would be to leave it. But if it's affecting your quality of life, or maybe you're worried about how it looks, you're not going for normal walks, it's very painful, then the gold standard for correction of bunion is surgical. And yes, it's one of the common surgeries that's performed in podiatric surgery, and it's highly successful as well. But the type of surgery you have will depend on the type of bunion that you have. Now, that being said, if a bunion is left, sometimes it can stay in one stage, but most of the time it can progress from stage 2 or stage 1 to stage 4. And if you don't know what stage 4 looks like, it's this big bone could go under all the rest of your toes, and you just have the lesser toe on top of the big bone. And I've seen patients just come in like this, and they're walking on their big toe with the rest of the toe on the top, and they have absolutely no pain. And they said, I don't want surgery. And you just get to understand them because it's not painful. But if it's something that troubles you, surgery is the gold standard.
All right, we'll just take one more and then we'll carry on and then come back to the question. Can corns be removed permanently?
Can I answer that? I'll start with that. We're going to do this together because obviously,
yes,
podiatrists, depending on, actually, Gerald, please, do you mind just taking that? Sorry, I just need to situation here. 1 second.
That's fine, no problem. Corns, it depends. There are different types of corns. Okay, we have hard corns, we have soft corns. There's one called neurovascular corn. Ignore the big name. That one is more common in patients that smoke. They can be removed, but what I see is that they always come back if we don't address the underlying issue or the underlying biomechanical issue. Biomechanical issue in the sense that if a patient has a toe deformity, okay, like the one we talked about in the slides, if they have a toe deformity that causes this part to rub, or maybe one area of the foot to take more pressure, because the patients will have to walk, except they're on a wheelchair. As long as you're using your foot and you're putting it in a shoe, if there's a biomechanical change, it will keep coming back. We can enucleate or remove the corn, put some things to offload it, or even issue insoles to reduce the rate of it coming back. So if you used to come back to take it out every 6 weeks, with some of the changes that we'll put in place, you might end up coming every 10 to 12 weeks, okay? Because it just reduced that rate of build-up if we offload it. Now, to answer the question, if they can be removed permanently, yes and no. Yes, in the sense that it depends on what kind of treatment we perform. So if it's a biomechanical issue and we surgically go in there and shave the bone, that is, causing that change in the structure, and close the skin back, and you don't have that biomechanical issue anymore, then the possibility of that corn coming back will be very low, okay? But if we just keep enucleating it and offloading with maybe insoles or some padding, then they can come back.
All right, Fumi, do you want to add anything?
Sorry about that. I had the call out to take. I think Gerald has said it mainly, and I mean the key thing is it depends on where the corn is. So, and like you said, it depends on the type of corn as well. So there's so many different types, like neurovascular, he mentioned. There's some that are like some are underneath the foot. Some might be on the top of the toes. There's some that are caused by maybe some sort of bony changes in the foot that may need insoles, etc., etc. So it all depends on the cause. If it's caused by shoes, for example, like you said, on the tops, maybe changing your footwear might be an issue to deal with it. Some people have surgical intervention, but like you said, the most common way of taking the corns out generally are enucleating them, which is when we take them out. Some people, their corns might come back in a month, some a week, some a year, some never. It all depends on each situation. So if that person can tell us a bit more about maybe that particular situation, maybe we can give a much more detailed response to it.
Okay, maybe during the general Q&A, I'll ask them to unmute and then explain a little bit more. All right, okay, Gerald, over to you. You can carry on.
No problem. I'll just
We'll take the rest of the questions later.
spare me one moment. I'll just share my screen. Can everybody see the screen?
Yes.
Yeah.
Great. So I know some of you are wondering why we have high heels in here. The men in the house, if you have wives as well that wear high heels, I think this will be a good session for you. So, I mean, high heels, we say lower heels are better. It's all about moderation. Platform gives more cushion. Feel free to use foot pads. So essentially what all this is saying is wearing high heels changes the structure of the foot and the foot mechanics as well. They've been around for a very long time, okay? But depending on the patient type and how often they've been used, okay, it might contribute to bigger problems or more problems. Now, in terms of high heels, some of the things to watch out for is just to ensure that the toe box of the high heel you're wearing is not too narrow. Because if it's too narrow, it will contribute to having a bunion because of that pressure that it will put on the big toe and as well as the small toe. It would also contribute to having corns because in that tight toe box, there's a lot of rubbing and a lot of pressure going on. There's a condition called neuroma. So what that means is it's like one of the nerves in the foot, they get damaged and they begin to form a little knot. And those can become very painful. They can lead to like a shock-like sensation in the foot, like pins and needle sensation as well in the foot. And sometimes it's been, with some studies, some recent studies done, it's been attributed to wearing very tight shoes like high heels as well. Now, if you look at the first picture, just look at the different angles of the foot. What that shows you is that the mechanics of it has been altered a lot from the ankle all the way to the forefoot where you have the toes bending that way. The mechanics has been altered. Now, with a position like this, what you get is that the patient might start having, it will cause pressure, increasing pressure in the knee. You might not notice this, for first few weeks wearing it for the first time, but over a long period of time, it will begin to add up and build up. And this can contribute to arthritis of the knee as well. With wearing high heels as well, one thing you can get is tightness of the calf, so the muscles in the back of your leg. Because with this position, what it does is it's contracting those muscles in the back of the leg, and you get that tightness in the calf. So I'm not sure if you can see me with the foot model in the video. Can you see me, Flora?
No, you have to stop sharing, and then
Okay, no, that's fine. So essentially with that first picture, with that foot in that position, there's tightness in the calf muscle. You will not be able to bend that foot to normal position anymore. And with that tightness there, it will contribute to what Fumi talked about earlier, which is plantar fasciitis, pain around the heel as well. Another condition that can happen with this will be the increased risk of falling. So the stability will be shifting, okay, depending on what ground you're walking on. If it's an uneven ground, you will not have very good stability, and the likelihood of having an ankle sprain or even a fracture in the bones when you have a fall wearing this is very high. So I just thought I'd throw this in the mix since we're talking about looking after your feet. There's no issues with wearing it, but just wear it with moderation. Okay, there's some people that might be using it as part of their dress code at work, which is quite understandable. But if you start getting foot pain or ankle pain, then it's time to reconsider your choice of footwear. Fumi, do you want to jump in on this one?
Yes. So we'll carry on as we are. Just if you continue with the sharing. So these are pedicure pointers. So what we are doing at this point is, yes, someone did talk about pedicures earlier. Obviously, that's like general caring of your feet. What we're saying here is, generally speaking, what we say is not to cut, like round your nails off. So normally we say just cut your nails straight across. But my advice generally is, because when we see people we all come in different shapes and sizes, So I always say, which is written here, it says follow the shape of the nail, because there are some people that actually do have slightly rounded nails, like myself. I have that, and I have other people in my family where their nails are just perfectly, straight. So all they have to do is just cut it straight across. So the general thing is, when you are taking care of your feet, just follow the shape of the nail and don't cut it too short. There should be a little bit of nail left. Sometimes some people like to cut the nails extremely short. That's not a good idea. Now the next point we've put on this bullet point is about cuticles. Now, I have had this said to me even when I'm doing feet. People sometimes will say, "Oh, can you do the cuticles? Can you do this, that, and the other?" Generally speaking, if there's no issue with the cuticles, what I normally say to patients is, let's leave it. If there's no problem, if there's nothing there that is obvious that needs to be done, because the cuticles are actually a protective barrier. And sometimes when you start disturbing them, pushing them back and doing this, that, and the other to them, sometimes you start introducing something now that you then have to start maintaining that wasn't an issue in the first place. But obviously, I have seen, the odd case here and there where the cuticles are maybe have grown out, they're a bit hard and they're a bit uneven. Then, of course, with that, it's, professionally, you make a judgment and it's something to do. But I'll say when you're doing your feet yourself, or even maybe when you go to see a podiatrist or a foot care person, where you go to like a pedicure, don't be too keen on having too much done to your cuticles. Yeah. Okay, so we're going to go to the next slide, please. Pedicure pointers, we're going to continue here. So what we're talking about is after you've cut your nail, following the shape of your nail, generally speaking, what we like to do is just to use like a file to just simply smoothen the nail edges, just lightly. Generally speaking, we like to do it in one direction so that nails are just nice. You don't leave any sharp bits there. Yeah? So you don't leave any sharp bits there. And then, you do that across all your nails. And then generally apply, some emollient and generally cream your feet on a daily basis. So this is just the bog standard advice, we tend to give. After you cut your nails, which you do as and when for yourself. Some people do it maybe every 4 weeks, every 6 weeks, some people every 10 weeks, depending on how quickly your nails grow, because everyone is different. Remember to dry in between your toes properly. Just dry them thoroughly. And, as I said earlier, don't put cream in between your toes because you want to keep them dry. And then just keep moisturize underneath your foot, on top of your foot, and, the toes, but just avoid putting things on the inside. Okay. And then, yes, we have a slide here about foot massage. Generally speaking, it's quite nice to have your foot massaged. It's like when people have a massage generally, it helps to relax your muscles. It helps increase like circulation. It's very relaxing. And even I personally enjoy having a foot massage from a professional. They have these people that do the back massage and everything else. But generally speaking, it kind of, helps with general well-being and, flexibility and making you feel good and, enjoying the quality of your life, basically. Gerald, please, do you have anything else to add?
No, I think you've covered everything. The only thing I'll add in terms of looking at coating your toenails, this is standard advice for toenails that are not thickened. There are sometimes, but that's a presentation for another day. There are some conditions that can affect the toenail and they'll make it quite hard to cut and quite thick as well. If you're struggling to have that done, then it's important to see a professional, because you cannot have that done in what's it called, like nail bars, because they won't even know what to do with it, to be honest. But that being said, sometimes with a ticking toenail, underneath the toenail, you might have pain on the skin underneath it, and sometimes it might become infected as well. When it becomes painful and you see redness around that toenail, then there's a possibility that there's an infection brewing underneath the toenail. Please see a professional when it gets to that point. So I think we're in the conclusion bit now. You want me to conclude for me?
Yeah, fine. Yeah.
Okay, so well, thank you everyone for sitting through this. To conclude, some of the points that we put here is that there's no need to live with foot pain. If you have foot pain, do seek help from a professional. There are lots of things that can be put in place to help you. Moderation is key. So in terms of footwear, high heels, the type of exercise that you do, moderation is the key to not having long-lasting problem, because the thing with the foot is we've been standing on it and walking on it from the day we started walking. So the possibility of having that build up over time and causing bigger issue is quite high. So try to place comfort first in terms of choosing footwear. Saying this, I'll just give an example of a patient that walks in, and you can obviously see that the footwear is the cause of the problem. We advise the patient about the footwear, and the patient say, "Oh no, I bought this footwear for about £500. They are very expensive, but they are not comfortable." So comfort first is what I would advise. Take good care of your feet. Check, look, and feel is very important, especially in between your toes. Have a look at your skin as well. See if there's any changes in color, any redness, pale any red dots as well as black dots around your foot. If it's something that is new that you've not noticed, you can take a picture of it and just monitor it over time. And if it's causing you concerns, please, go to your doctor. Feel free to visit your doctor, nurse, or pharmacist with any questions that you have concerning your foot. Thank you very much.
Thank you so much, guys. All right, so there's quite a few questions. If you want to ask a question and you want me to unmute you, just raise your hand while I go through to the ones in the chat. So the floor is open for more questions. So first one from B is terbinafine cream over the counter and tablets, which is prescription only. Is that the gold standard for treating most fungal infections?
Well, my take on this is there are very many different antifungal creams. You've got Dactarin, you've got you've got Lamisil, which is of course one of the very popular, very well marketed ones. And there are lots of other ones, other antifungal creams there. When it comes to the prescription only tablets, again, there are also several others as well. So obviously, when something is prescription only, that's going to be down to your GP to decide, what is the best way forward. Yeah, that's all I will say on that. But please add to it, Gerald.
I mean, terbinafine is recommended when you look at the NICE guideline in the UK. I'm not sure where you are, the person asking the question. So it depends on guideline and country-wise as well.
It's a pharmacist action, actually.
Okay, in the UK.
In the UK, yes.
Okay, yeah. If you look at the NICE guideline, it's one of the recommendation that is there for fungal nail or fungal athlete's foot, fungal infection generally. But it's gold standard. I would say yes, because it's quite popular and very common, but it's patient specific as well. So depending on which kind of patient we're looking at, if they've had that before, if they've reacted to it, sometimes we've had patients that we place on terbinafine for a very long time and it did not make any difference, to be honest, after a few months. We had to go back, reconsider and change. So yeah, it's highly recommended by the NICE guideline, but we also need to work based on the kind of patient we're dealing with.
All right. Okay. Thank you. Next question. If you are not diagnosed as having diabetes, but have numbness on the feet, what could be the cause of that?
There are other reasons for getting numbness in the foot. Off the top of my head, I know there's a certain vitamin deficiency that can cause it, but I don't have that on top of my head. Maybe Gerald might have that. But there are also, other causes. There could be nerve entrapment. Some people might have a back problem. I've had patients that have had a back problem, sciatica or some sort of nerve situation going on when their GP has referred them on to actually see that was what was causing the problem in their foot. So there are other causes of numbness. And it's probably best to have it investigated if there's like generalized numbness, in the feet to see what the cause of it is. But Gerald, please add on to this.
Yeah, apart from diabetes, well, that being said, I'll say not every patient with diabetes experiences numbness in the foot. The diabetes has to get to a point where it's poorly controlled for a very long time before it starts damaging the nerves and the blood vessels as well. But saying that, like for me highlighted, there are different reasons why you can have numbness in the foot. I'll start with the most local one, will be neuromas. So neuromas will be like, let me bring this model again. So we do have nerves that run between this bone here. Wearing tight things or any trauma in that nerve, you have like a little band, damage to that nerve as well. You might get numbness in your toes. You might get numbness in that particular area. You could get shooting pain as well, just nerve damage in a patient that is not diabetic. Apart from that, another cause of numbness in that area could be what we call needle-induced numbness. So a patient that has had maybe 1 or 2 injections in the foot, maybe steroid injection that could cause a damage in that area, they can start getting that numbness as a result of from that needle. Looking at the body system and possible reasons for that could be vitamin B12 deficiency. Vitamin B12 is known to to help with protecting the nerve, and if there's deficiency in that vitamin, then it can contribute to nerve damage, okay, which can lead to numbness. Fumi already highlighted lower back problems. So people that have lumbar disc issue, problems with the lower back. It could also be arthritis in the lower back as well. Anything that compresses the nerve or entrap the nerve in the back. One of the nerves in the back, called the sciatic nerve, is the longest, okay, in the body, because it goes all the way from the back, and then it divides in the back of your knee, goes to the foot, and then it supplies different areas. So if you have that bulging of your disc in your back, and then you get back pain and it's entrapped, you could get that numbness in your foot as well. So that's one of the reasons. So issues with the lower back. Another reason I'll say is what we call alcohol-induced neuropathy. Patients that do take alcohol, abuse alcohol over a long period of time. And one of the reasons for this will be vitamin deficiency as well, because taking alcohol would make it difficult for certain vitamins to metabolize in the body. Okay, and with that, patients might also get disturbance to the nerve and lead to numbness. So it's not just there's diabetes. There's a lot of things that can contribute, but these are the major ones.
Brilliant. Thank you so much for that. All right, Dr. Salisu, you have a few questions. Go for it. I've asked you to unmute.
Yeah, thank you so much. Such a long time. I've missed this program. I just want to ask concerning our profession. Thanks to the presenters as well, and for taking time to take care of us. God continue to take care of you guys. For we that walk a lot, there are 2 questions now in one. Is it good to walk barefoot? I've dropped that in the chat. Then for us in academics that walks a lot, round and round, teaching from classes to classes, is there a kind of deficiency this could cause? Because I find out from most of my colleagues that when we come around to discuss, they find out that each time you want to wake up, there's not any underlying disease. We find out that the ankle is so difficult when you want to get up in the morning to be as if it wants to collapse. So I don't know how much work is good for based on the profession, or how less is it? This is just on the general health ground. Thank you.
Fumi, do you want to take that, or do you want to take it?
I can take bits from there, and we can sort of do it in bits. In terms of the ankle and how much walking to do, I think that is like kind of specific to each person, because it really depends on a lot of things. Some people may have some issues with their ligament. Some people may have a strain of some sort that has caused weakness in the ankle. Some people, it could even be weight. I couldn't say the type of footwear that's been used. All these things are contributing factors. So the first thing, obviously, is if you're going to be doing a lot of walking, then, appropriate footwear, it always starts with that, because appropriate footwear can do so much, in terms of the quality of the comfort of the foot, and obviously this is a very, I think, sort of individually specific question. So I don't know if there's issues of arthritis going on there, possibly. So I think it's sort of a bit difficult to answer that one, but
okay.
Yeah, but Harold will say about that.
I think one of the questions about barefoot walking, I think.
Yes, if it's good. What's your take on that?
Barefoot walking is becoming increasingly popular. If you go to the gym, you see people with these barefoot shoes and all over the place. But there are some podiatrists that do advocate for it. In terms of barefoot walking, like we said in the conclusion points, moderation is key, and it also depends on you as well if you're comfortable. with barefoot walking, what I find is that patients that walk barefoot, it gives your foot the foot muscles, because you have a lot of muscles in your feet. It gives them the opportunity to be stronger. Okay. But that being said, there are some patients that when they walk barefoot for a very long time, they start having this callus or hard skin around the foot, which can become painful and become ulcerative as well. So just doing it in moderation, it's important.
Awesome. Thank you.
All right, Dr. Sally, so you had one again about athlete's foot. What was the question? All right, well, she's unmuting her.
Athlete's foot,
yeah.
Yes. We heard about so many fungal creams, drugs, and I've heard that sometimes the drugs can be they used to have a lot of strong side effects if we are giving drugs for treating athlete's foot. But check the component of most of this antifungal, and I begin to wonder. I think some actually work better than the others because of the components. So, and the local women would say once you use what was sulfur and you mix it with whatever, maybe shea butter and something, you are good to go. So I became curious and I said, okay, maybe you'll be able to advise us better. What exactly is the component that is the most active that we should search for when we're trying to get one fungal cream for the athlete foot? Because it's very common here, especially we that put on socks, like that. Thank you.
I think that's a more specialist type question, isn't it? For me, what do you think?
I mean, while the question was being asked, I was Googling, so I'm going to just put my hand up. And I Googled active ingredient in Lamisil cream and Lamisil spray. And, it's, like you said, it is specific. But if you Google, it just says it's tabanafine hydrochloride 1%, what W/W, So I am not an expert in pharmacology, so I don't want to give any misleading advice. But this is what it says on the internet. So yeah, I can't say any more than that.
Yeah, I mean, in terms of active ingredient, I don't think that's one of the we know the name of the medications and the actions, but in terms of the active ingredient in there, it does depend. But terbinafine, like Fumi said, is a quite popular one that we use for patients that have fungal infections. But in terms of different facets of it, I think that's more specialist pharmacology area. Actually, I think I was going to ask you that as a pharmacist to tell us which one is best, because we do have that struggle as well in podiatry.
Gerald, are you asking me?
No, I was just generally bouncing it back,
right, okay,
to the pharmacist in the house to tell us what is best.
They might be able to.
Well, I mean, like you said before, you might try one thing, it doesn't work, then you try something else. So yeah, I'll see if any pharmacists can answer that. I'm trying to think off the top of my head. I can't think of anything right now. So while we're doing that, let me just ask the next question. Somebody's asked about herbal remedies for athlete's foot.
I mean, when it comes to herbal remedies, I have to be quite honest. I don't recommend them. I've heard of some, but because of the way that, we are trained, some of my patients have told me about tea tree oil. I hear a lot about that, and I'm sure there's some truth in it. But personally, myself, because it's not something, that maybe I've paid a lot of attention to as in a go-to treatment. It's not something I endorse, but I've heard of people saying, tea tree in certain preparations can be useful, but like I said, it's not like my standard advice. So.
Yeah, I mean, then again, it's what works for the patient, because people are proactive about their health and they try to find different ways to help themselves. Personally, I don't have anything against it. it just depends on what works for you. If it's something that is topical that you apply, not something systemic that you put together and drink, it could have different sort of effect. But that being said, some of the things you apply to your skin, it still gets absorbed into your bloodstream anyways. So it's just erring on the side of caution and go and read research about it. If there's any evidence, I personally have not read any paper on herbal remedies for fungal infection, but yeah, it's about using evidence-based practice as well. So if there's any evidence that shows that it works, I'm really not aware. But tea tree oil is one that a lot of patients advocate for.
All right. So essentially, speak to your healthcare professional before using anything. I think that's the message we want to get across here. Okay, the next question is Olabode, I'm going to ask you to unmute after I ask this question because I need you to explain what you're asking because I couldn't understand your question. All right, so Viva is asking, please, what causes sores in between the toes and the sore smells? What could be cause of those sores?
Thank you for the question.
Yeah,
thank you for the question. So sores in terms of ulcers or wounds or blisters.
No specifics given.
Okay. I mean, sores can be a wound, it can be a macerated skin, it can be a blister that is there. It can be a corn or a callus or hard skin that would just have this indentation in the middle that can also be very painful. The short answer is rubbing and pressure, and as well as macerated skin. So if you're applying cream between your toes, you're not drying your toes properly, you're wearing occlusive footwears, it gets really hot in there, the skin might start to break down, and you might get some sores in there as well. If there's excess rubbing in that area, that can also contribute to having painful sores around there. Wearing the wrong footwear as well is one of the biggest contributor to that, as well as changes in the shape of your foot.
All right, Fumi, anything to add?
Well, I think Gerald has said it more or less. The key thing is, the sores can be caused for frictional pressure, like you mentioned. Sometimes some people put powder and things like that in between their toes sometimes that can sort of congeal and can cause problems, So that's a very sort of general question. And I think the key thing is, he says, how can it be treated? So having good, like a routine, if it's something to do with maceration, where you get a lot of sweat accumulating, that may be causing the bacteria, to sort of generate and the smell. Usually it's caused by bacterial breakdown generally. There may be just having a good regime of washing in between the toes, drying them thoroughly, keeping them clean. If there's any sores, they might need to be treated by a nurse, doctor, go to the pharmacist if there's actually anything weeping, because there may be other reasons for that, So if there's any open wounds, which is probably what I'm thinking, is it a sore? If it's an open wound, then obviously that needs to be treated properly, by a nurse, maybe doctor. They may need some sort of antibiotics or some sort of medication. So seek some further advice is the key thing I would say on how can it be treated.
All right. Great. Okay, next question is, what is pincer nail and how is it managed?
What, pins and needles?
Pins and nails.
It's a question. Yeah, it's a question from YouTube. Pincer nail. How to manage pincer nail? Or what is it?
So, are you happy for me to answer?
Yeah.
Yeah, I mean, pincer nails, it would be good for me to show you a picture of what it looks like.
Okay.
But essentially, you have the way the nail grows, it pinches on the underlying skin, and you just have sort of like a nail in this shape, okay? And you have your skin in between, so it's just pulling it up and growing in that direction. That's what a pincer nail is, and it can be very painful. But I've seen
Nail.
pincer.
Pincer. Oh, pincer. Okay, sorry, I didn't hear.
Yeah, Gerald, I mean, answer the question, but if you can find a picture for us, then we can show it later. But yeah,
Yeah. So that's what a pincer nail is. It's a nail growing in a different shape. And one of the causes it can be genetics. You know, some people that might carry it from maybe a family member. It can be as a result of trauma. It just changes the cells that produce those nails, and you get that shape. Treatment, yes, conservative treatment might just be going routinely to visit your podiatrist, where they can trim the nail in such a way that it relieves the pressure on the skin that is causing that pain. For long-term solution, it might be toenail surgery. So they would remove the nail and they will use a chemical to burn the cells that produce that nail so it doesn't grow back. But the sides to that is that you will be left with no nail in that area, and the nail doesn't come back, so it doesn't cause that problem. So it can be conservative management or surgical management, or even changing the type of footwear that you wear so it doesn't put too much pressure on the nail.
All right. Okay. Thank you. All right. When your nails look white and pale, could this be a vitamin deficiency? What could cause that? And this is in the person of color. I don't know if that matters.
I mean, for me to answer that one, it depends, because there could be different causes for a nail to look. It says white and pale.
Yes.
Do they mean, is it brittle? Is it opaque? So obviously there's some change in the nail. There can be some vitamin deficiencies that can cause, particular changes in nail, but, without really seeing it, it could be caused by different things, there are different reasons why nails change color,
All right. Fumi, you asked that question. Is another Fumi. Please raise your hand. I can find you to unmute yourself if you want to.
Maybe if you
elaborate on that.
Information, please. Yeah.
Yeah. So just raise your hand and I can find you and ask you to unmute if you want to ask that and clarify. Okay. So next one. Some people might have missed it earlier where you mentioned about what podiatry is. So I have a question here. Is there podiatry in Nigeria? What is it? How can it be introduced? Some people don't know what podiatry is.
Do you want to answer that one, Gerald?
Yeah, I can jump in. So thanks for the question. I think that's a very wonderful question. Podiatry is a specialist area that deals with the lower limb. Okay, so specifically the foot and ankle. Your question about if we have podiatry in Nigeria at the moment, I'm not sure, but from research that I've done, it looks like we don't, or there's no podiatry in Nigeria, to be honest. Introducing podiatry into Nigeria is a discussion for another day, because you have to go through different there's different pathways and different things that has to be done to make that possible. Yeah. So, just to add, in terms of podiatry as well, being a foot and ankle specialist, some people think that it's just about the toenails and that's what we do. But there are different specialist areas in podiatry. So when a student goes through the podiatry school, I'm speaking for the UK for now. I think they have a different version in the US, where when you graduate, you become a doctor, a DPM, which is Doctor of Podiatry Medicine, and they graduate with a surgical ability as well. But in the UK, when you complete the 3 years program, or you do an MSc pre-registration 2 years, and you become a podiatrist. You work with the NHS, you can go private, you can open your own private practice the next day if you want, or if you're confident enough. And then you can go into different specialist areas. So there is diabetic foot specialist, podiatrist. There is podopediatrics, which are podiatrists that look after foot deformities in children. There's also forensic podiatry, where you have podiatrists that work with crime unit, where they look at people's video gaits, like how they walk and footprints, in order to use that to fight crime. So apart from forensic podiatry, there is sports podiatry as well. So you can work with football clubs, basketball clubs, You can even work with ballet dancers, people that do cyclists and the rest of that. One of the other area in podiatry will be podiatric surgery, where it's more like orthopedic surgery, but for the foot and ankle. But to do that after going through School of Podiatry, there's about an extra 7 to 8 years of training to become a podiatric surgeon. And that way you get to do things like bunion correction, soft tissue surgeries like removing, damaged nerves and, different type of bone surgeries in the foot as well. So it's quite a vast area.
Wow, amazing. Didn't realize it takes that long. Well, if you want to become a surgeon, I suppose that makes sense. All right, thanks for that, Gerald. Okay, back to Fumi and the nails. Do you want to unmute yourself? I've asked you to unmute. I found you now. All right, go for it.
Hello, everyone.
Hi.
Hi.
So what was the question?
What
For
questions to ask? Yes.
I mean,
Clarify.
for me.
Yeah, clarify what you were trying to ask in terms of
Okay, so my nails are like got white patchy. I don't know how to describe it. My nails are not white, but they got like white patches on it, and they're always like very pale. And I think my namesake said something earlier. Is it brittle or something? Yeah, it is. So I was just wondering if it's a deficiency of a vitamin or something.
How long has it been? Was it something you noticed in the last 6 months or something that's been going on for a while?
My nail has always been like, yeah, very like brittle like that. Yeah, but I noticed that sometimes you have the white patches, sometimes it disappears, sometimes it comes back. And it easily breaks. It's not like strong.
And is it thin?
Yes.
Right. I mean, I can't say, to be quite honest, I don't want to be guessing. I don't know. The first thing I will say. Do you mind if I ask, where are you based?
UK.
All right, because I mean, what I will suggest is, if you could either see a podiatrist so they can give you like a proper consultation, maybe see your GP or ask maybe your GP to refer you to a dermatologist. I don't really want to say any more than that because I don't want to, if I'm not sure, if I can't see something, it's difficult to sort of give more from my own side. But I mean, I don't know if you want to add to that, Gerald.
What I'll say is, I mean, if there's a white patch and it's brittle, which means it breaks off and then it grows back and then it breaks off again, it means that there's an underlying issue, which can be anything. It can be just a traumatic nail that is struggling to heal itself. It can be vitamin deficiency, like you said. There are other systemic conditions that can contribute to that type of nail, okay? But without the benefit of seeing the nail and taking samples and doing further assessment, my advice would be to seek professional support.
Okay. Thank you. Can I just ask a quick question about the walking on barefoot? What did you say about that? Because I know that it's called grounding and it's good, very, very beneficial. But I think you said don't walk on barefoot, if I heard you correctly. But it's like a bit confused. Some people say walk on barefoot is good. Some people say it's not. So can I just clarify what you think about that?
Mm-hmm. Thank you. So basically, in terms of barefoot walking, the positive aspect is that you're engaging all the muscles of your foot, okay? And that way they are active. They're pulling bones and joints and things like that. So you get a stronger musculature in the foot. But the only place where we have to err with caution, if you're young and fit and you have no underlying foot problem, then that's absolutely fine. If you're not getting any pain in your joints or your ankle, and it does not affect your daily activity, then that's fine. Okay. If you're at home, you can, go around barefoot in the house. But there are some patient group that we advise not to walk barefoot. For example, patients with diabetes, patients that have lost protective sensation in their feet, because if they damage any areas of the foot, they might not know because they can't feel it. And that way they can't report it, or they don't report it. And they only come when it's a big ulcer and an infection in the foot. But barefoot walking in general, when you're young, fit, and healthy with no underlying issue, I don't see any problem with that. But when you notice that you start to get callus, callus doesn't know age. So callus can happen. So callus is just hard skin on your foot. It can happen even if you're 13 years old. It's a way the body tries to protect itself by generating hard skin in an area that is constantly taking pressure. So if you're walking barefoot and there's that constant impact, especially in the ball of your foot and your heels, you will start to get those callus patch, okay, or callus patches around there. The issue with callus is that it's just like ballet dancer. If you look at the ballet dancer's foot, you see those heavy callus there. They are protective. But where it becomes an issue is when it carries on for a long time. The skin underneath that callus will begin to break down. So when a callus starts to become painful, then it's time to go into some comfortable shoes and, or see a podiatrist as well, because sometimes there can be ulcers underneath that callus. So I'll just give you a quick story just to cover this, round this up. We've had patients that come in with a callus and they said, oh, this callus is not painful. I just want you to reduce it a little bit. As soon as you touch the callus, it's a bit soft and squishy. I warned the patient first. I said, there's possibly an ulcer underneath this callus, because if we don't do that, the patient will say, you've caused an ulcer, or you've given me an ulcer. I came in, everywhere was covered. There's just a hard skin. So by the time I put in the scalpel to debride that callus, the pus came out and we just deroofed it, and there was a massive ulcer underneath. So what I'll say is, when a callus becomes painful, when you're doing your barefoot working, or don't let it even get painful, just do it with moderation and alternate.
Thank you. Thank you for that, Gerald. All right. Before I take Gani's question, let's take one in the chat. Can wearing certain types of shoes, like flat shoes, cause pain underneath the feet, even if they seem comfortable? The person says she experienced this last year, and the pain was particularly in the mornings after waking up, but stopped after she stopped wearing the specific pair of flats. So pain with flats shoes.
Yeah. For me, do you want to take that? Or?
Well, that is, again, this is like a person-specific question, you see, and flat shoes don't always cause pain, but obviously it's good to wear footwear that is supportive and appropriate for each person. Sometimes if you have a footwear that's not providing you with the right support, or maybe even the person may have had an episode of, plantar fasciitis, possibly, I couldn't say, because this is like a classic, story of plantar fasciitis, of when you, particularly in the mornings after waking up, So all I will say is I cannot answer that, but definitely, all I can say is I won't say that flat shoes will cause pain underneath anybody's foot. So there might be other things going on. You understand me? So that's just my take there.
Is it okay to add to that?
Please do. Please.
Okay. So, I mean, in terms of wearing flats, what you get with flat shoes is that the arch, okay, would collapse, okay? So you get patients that have flat feet as well. And like Fumi mentioned, in terms of plantar fasciitis, you have a band or fascia that goes all the way from here to here. Okay, if the shoe is flat and your arch is not well supported and it stretches that way, the possibility of getting pain at the bottom of your foot increases. So flat shoes can contribute to having pain in that area. Apart from that, it's just like punching a wall. So I think in physics, they say for every action, there's an equal and opposite reaction. So if you punch a wall with your bare hands, it depends on how much force you put in, you will get that force back. But if you put a glove and punch that wall, the glove will serve as a buffer, right? So you don't get the same ground reaction force back. So imagine wearing a shoe that is too flat, and with your body weight, that constant heel strike pressure on the foot, you're getting back the same force that can go through your ankle and go to your knee as well, which can contribute to knee problems and ankle problems. But wearing shoes that would properly buffer, not too cushiony, because if it's too soft as well, that affects your stability. So something that properly buffers and acts as a buffer between the bones in your foot and the ground, okay, that can help. Okay. But just like you said, it's patient specific. If a patient is young, fit and well, there's no issue with the skin, the fatty padding in the foot is still intact, then flats will not really be an issue. But if the fatty padding is not intact, especially if the patient is elderly and the skin in the foot is beginning to thin out, then wearing flats will contribute to more pain in the foot.
All right, thank you for that. Mr. Gani Lawal, unmute yourself, please.
Sir.
Thank you.
Hello, everyone.
Hello.
Hello.
I'm Ambassador Lawal. I want to appreciate all of you professionals for coming up and for having me. I was invited there by my classmate, Mrs. Coker, Mojisola Abbas, and she implored me that I must attend, and I have a lot of respect for her. However, my contribution will be by way of finding out whether it is true that all organs in our body have something to do with some lines on our steps. And there's a mythology that the more you walk, the more you strengthen all these organs, the heart, the liver, and the rest of them. And some even have it that when you want to sleep at night, you try to oil those steps. While doing so, you are also feeding all the organs in your body. Is there any truth to the fact that all organs in our body are somehow connected with our steps, those lines on our steps underneath our foot? It's funny, right? The kind of mythology to me.
I've heard of.
I don't know any science that that has proved that. So now that I'm in front of professionals, maybe you will educate me. Thank you.
Well, I mean, I've heard of reflexology, and in fact, even I've been on a course a few years ago. It was like a one-day course on reflexology. But you see, for me, and this is a personal thing for me, it's not something that I have any objective evidence of, or maybe I haven't read any. There might be something out there, maybe I haven't sought, but I cannot add to that. I mean, all I can say is obviously walking is very good exercise for the heart, and the heart is what supplies all the, the whole body with life, with the blood that we need. So obviously walking is good, but I can't say any more than that, really and truly.
So there's no connection between our organs and the lines on our instep.
No, that's not what I'm saying, sir. What I'm saying is I'm only speaking for myself. I'm not speaking for this profession. I'm not speaking for this platform. I'm only speaking as myself. And I'm saying that I am not aware. So that's just me, one person. There are like 10,000 podiatrists, and you probably have other people may say something else. But what do you have to say, Gerald?
Well, I mean, thanks for the question. Like for me said, I've heard about reflexology as well. It's a different field entirely. But that being said, I've heard about, if you press this area of your foot, you stimulate a different organ in the body, something like that. But there's something called, for the medical professionals in the house, there's something called myotomes, there's something called dermatomes. And this is where you have a group of muscles. As you appreciate, different organs have different muscles as well. A group of muscles supplied by a single nerve root, okay? A single spinal nerve root that comes out from the back. And sometimes, not sometimes, we have those nerve roots, that come all the way and bifurcate or divide and supply different aspects of the foot. as well. So if you are stimulating a particular nerve, there's a possibility that the organ that nerve would also supply can get stimulated. And yeah, that's the whole idea behind the reflexology thing. But I'm not an expert in it really. But there's a connection sort of.
Okay, I have Marianne who wants to contribute. Marianne, could you raise your hand so that I can ask you to unmute? I can't find you. I saw you now, but I can't see you again. She's sent a message. She wanted to contribute to this question. Well, looks like her.
While Marianne is coming on, I
Yeah.
want to know that, this is a really good question, I have to say, because it's a question that's been lingering behind my mind after I went for that one-day course. And it's something that obviously at some point, I want to learn a little bit more to see if there is, to see what this connection is. Because I have had many people, especially people from Asia, have told me about this, and they believe in that. This is what they've told me. So I've heard quite a lot about it. It's just that I don't know more.
All right. Okay. So I don't know if Marianne is having issues on muting. We'll come back to the question, sir. Let's just go to Mr. Richard. If you could unmute yourself, and then we'll come back to the question once we find Marianne. She might have something else to contribute to add. Richard, I've asked you to unmute. There you go. And then you can ask your question. No? All right. Any other questions while we wait for them to unmute? There's a question about Shako's foot.
Someone wants to contribute to the last question.
Okay, Eniola. Okay, unmute yourself then. And then add to that one. I've asked you to unmute.
Thank you very much.
Okay.
Thank you I'm Dr. Ole Erisho. Thank you for the explanation and the lecture. It's been really great. I've gained a lot from this.
Thank
okay,
you.
As regards the last question, I think I want to align with the guest speaker that spoke about dermatomes. I think that is what is used in acupuncture. The link between our palm and the soul to organs in the body. And it has to do with innervation. Most of the organs that we have in the body are actually connected to some parts of the palm and some parts of the toe through the innervation. And that is what the acupuncture specialists actually explore in treating pain of the various parts of the body. That's just my contribution. It is innervation that links the organs and the foot, and that is what the acupuncture specialists, that's what they actually use. That's the scientific explanation for the acupuncture. Thank you.
Thank you so much, Doctor. Right, Mary, I can't, for some reason you can't unmute. Maybe we should have had a reflexologist on today. We should have anticipated that question. Okay, anyone else want to contribute to that that one about any other healthcare professionals that want to contribute to that? We'll see if we can get an answer for you, sir. It might not be today. We might have to do part two to this. I'll bring on a reflexologist. I'll see if anybody responds, and I'll ask you to unmute again. Okay. All right. Mr. Richard, are you ready to ask? Or should we just go ahead with Shako's foot? What is Shako's foot? What is the implication? What is it? Fumi and Dr. Gerald?
Well, it's where you get a breakdown of the joints, where you have nerve implications. You see this a lot with diabetics, where the joints is like they almost get like a breakdown of the joints. I know it says here, how often do you see this? When I used to work in the hospital setting, which is about over 10 years ago, I haven't done that sort of work for quite a while now. it was something we saw often. And they used to use casting to try and offload the pressure from the affected foot and dress it. And it was something that was able to get to that stage where yeah. Anyway, for people to get to that stage, they've sort of reached like in their journey of diabetes, it's sort of a very like chronic problem, and it's not good because a lot of them sometimes end up with having other things done if they don't get healing as a result.
Is this something that might require surgery or something?
In some cases they do, but it's not an area to be. I mean, I want to maybe hand this on to Gerald if he's happy to answer it, but it's not an area that I work in currently or for the last maybe 10 years or so, because I don't work in a hospital setting, and this is sort of more the sort of thing that once you see it, I kind of refer it to hospital. It's not this kind of thing I treat at the.
All right. Okay. Over to you, Dr. Gerald.
Thank you. I mean, shackle foot. I'm just being conscious that we have non-medical professionals in the house, so we need to explain it in such a way that they can
yes, please.
understand it as well. So, I mean, basically what it means is the bottoming of the foot, or, the gradual dislocation of the bones in the foot. And essentially why that happens, like Fumi said, you can have that in patients with poorly controlled diabetes that have gone on for a very long time. If you throw in the mix neuropathy, which is problems with the nerves in the foot, at some point, there's this massive systemic outburst where, the bones in the foot will begin to soften. I like this, my foot model here. It just helps to contextualize things. So the bones in the foot will begin to soften, and it will react to any weight or trauma, and it just starts to change shape. Essentially, when the patient stands or walks, the midfoot will begin to dislocate. So there's a grading system that they use for it. Depends on, based on that grading system, it just goes by what areas of the foot has been dislocated. So essentially what you have is the midfoot will just bottom out, and then you get a rocker bottom type of foot. And in a patient with diabetes, what you get is that area will be an area of peak pressure, and it will be taking a lot of load. And with that, you get that ulceration as well as probably infection that goes into the bone and becomes sepsis and lead to amputation. So basically what it is just softening of the bone and dislocation. Now, if we pick it up at the point where it just started, what we do is to, send them to the acute team in hospital, but we offload it right there and then. The key thing is offloading it and getting the patient not to wait there until they go past that phase, because it will get to a point where the bones will begin to solidify again. Okay, so it will soften. If they stand on it, it dislocates and solidifies in that position. If we're able to catch it early and offload it, then we'll reduce the chances of that bone bottoming out. Now, the question about surgical correction is something that has been increasingly done or considered at the moment with podiatric surgery and orthopedic surgeons working together. I'm speaking for the UK context now. So there's this plan in place with pod surgeons, orthopedic surgeons working together to help this increasing shackle foot problem or pandemic, if I'll call it, with construction of the bones to take that pressure away from there. I hope that answers your question.
Okay, I hope it answers their question too. Yes. Last question, I think. What is the cause of an itchy foot on the sole of the feet? Could it be related to diabetes when the sole of the foot or the feet are itchy?
Not necessarily. People without diabetes get itchy feet. It just depends. I mean, if it's caused by some sort of fungal infection, the feet are very susceptible. Like we said earlier in the talk, to fungal infections. Fungal infections are opportunistic infections that are sort of there. So it's not necessarily a connection with diabetes, as in, a lot of people get itchy feet. So it's a matter of treating the cause of the itchy feet, if it is a fungal infection that's causing the itchy feet.
Okay. Alrighty. Let's see. Any more questions? What could be responsible for athletes' foot that would not go away completely despite an absence of diabetes?
So, do you want me to take that for me?
Yeah.
Sorry, come again with a question.
What could be responsible for athlete's foot that would not go away completely despite the absence of diabetes?
Okay, and can I just bounce that back in terms of not go away completely? Has it been treated completely?
That's a good one. Okay, Mrs. Lawal, you asked the question. Do you want to unmute and just answer that, please? I've asked you to unmute. Yeah.
My network is very bad, but let me try. So the patient has been treated, goes off, comes back, and he's been on it for so long. When he treats, he goes off, then he comes back again. And on all that he knows to do, including foot care and all that. And that athletes will just keep coming back.
Okay. Well, thank you for the clarification. I think in that case, when it comes to treating it, one of the things that might make it come back is it's been inadequately treated. Because with fungal infection, it can take a while to clear off. Sometimes when they don't see the physical presentation, they might stop using the medication. They might stop using the cream as well. And then, after a while, it comes back. So inadequate treatment can be one of the reasons why it comes back. Importantly, I would say lifestyle modification. So it's important for us to ask the patient as well how they've been treating it, how they've been using it, if they're using it properly, because sometimes we do the prescription, give it out, and the patient goes back and, follow the wrong process. So we need to understand the treatment process that the patient is, undergoing. So making sure they are doing the right things as well, okay, just to close every little corner. Under lifestyle modification as well, we want to consider things like footwear, socks. Are they wearing the same socks every day? How are they washing it? Are they washing it inside out in hot water, just to make sure they are killing that fungal, the infection that is still left behind in their socks. Another possibility might be there's somebody in the house that probably has the same fungal infection that is not treating it. And our lovely patient here gets treated and they go back at home and they pick it up again from a family member, or maybe by using public bathrooms or swimming pools and places that are damp and wet. They can easily get reinfected in that case. Now, if it keeps going and coming back, I think it's very important for the patient or the clinician to consider systemic issues that can be contributing to reduced immune system, maybe diabetes, maybe other systemic issues that can contribute to reduced immune system, because it's an indication that the body is not, strong enough to ward it off. Because fungal infection can be self-limiting, which means it can come and go on its own without even being treated. But if it keeps coming, going, then it's important to consider other factors that might affect the immune system that could be contributing to that. That's my my take on it.
Fabulous. Thank you very much. All right. While I'm looking for if there's any other questions, can we also appreciation for our speakers today? You can unmute yourself. You can pop a message in the chat for them. Thank you so much, Dr. Gerald and Fumi. Let's show them some love in the chat. Unmute yourself and give them some feedback. I can't see any other questions in the chat, so I think we are done for today. Thank you, everybody.
Thank you very much.
Thank you. I can see
you.
lots of
Thanks for
clapping in
coming.
the chat. Yes.